supporting. We have with us people from all over the country to hear this very exciting program by Harvard's Dr. Deepak Bhatt and two of our great cardiology colleagues from the University of California, Nathan Wong from UC Irvine and Bill Bommer from UC Davis, my undergraduate alma mater. So the information will be in the chat session about the CME survey link, but we will need you to fill that out by midnight tonight in order to get your 2 credits. I want to thank everybody for coming from the 4 winds to join us for this really groundbreaking work that's being led by Harvard on Icosapent Ethyl. We will have a formal invitation of Dr. Deepak Bhatt momentarily. Meanwhile, I want to thank our amazing sponsors that have kept this work going now for a dozen years, including the National Institutes of Health, the California Department of Public Health, the Los Angeles Department of Public Health, the Santa Clara Health Trust, our University of California Schools of Medicine, Public Health, and Pharmacy, USC and Stanford, and the American College of Cardiology. We also want to deeply thank our biotech industry for helping us all to survive this pandemic to the degree that we're making this amazing progress. And our biotech sponsors are listed here. Our longest sponsors are Johnson & Johnson, Genentech, Novo Nordisk. We also have Boehringer Ingelheim, Amarin, and Amgen. The Stroke Awareness Foundation and the Tennis Getter family, the Judy White family have all made this life-saving work possible. Next slide, please. And most of you know me. I have been leading quality improvement in California for a couple of decades now and got my training where Dr. Bhatt is out there at the Kennedy School of Government at Harvard. Next slide, please. We are a collaborative of amazing people who have made this work happen. And one of them is the former chief lawyer for the state of California, who I worked with for a couple of decades. Still, he's a wise counselor continuing with this project. Warren Barnes, who's once he graduated from his state service as the chief lawyer for many years, having helped me write the Patient Bill of Rights, including the independent medical review and the right to second opinion. He continued consulting with the Right Care Initiative while he ran a church as a minister, the Presbyterian Church in Sacramento. He gave us this important framework, which is that when we gather in the Right Care Initiative, we're competing against disease and not each other. And this has proved to be very important because people have gotten to know each other through this forum, and they collaborate in pursuing many of the things we're about to talk about. Next slide, please. Our goals are simple, and they're complex at the same time. By bringing people together and getting them energized about controlling cholesterol and subparticles of cholesterol, which we'll be hearing about today, also controlling blood pressure and blood sugar, we know that we can drive down events. That's what you see in the graphs behind me, where it's intensively pursued. You can significantly drop acute myocardial infarctions. Next slide, please. So the formula we teach in all of our sessions is, here are the advances in medicine that we need to quickly adopt instead of waiting that 17 years. These are strategies that we deploy in every one of our meetings, including nationally endorsed guidelines. We will be hearing about some European guidelines in a little bit. Next slide, please. I'd like to introduce our wonderful chairman, Dr. Bill Bommer, former president of the California American College of Cardiology. He has trained many of the cardiologists in California, and he continues to lead amazing work. And most of you know him, so let's go ahead and give the microphone to Dr. Bill Bommer, and thank you all for joining us.
Thank you, everyone, for joining us. We have over 60 participants right now, and we probably will get over 100 as people are getting signed on. We have a great program today, and the program is related to residual risk of cardiovascular disease. It is featuring the speakers shown here, Deepak Bhatt from who is the Executive Director of Interventional Cardiovascular Programs and Professor at Harvard Medical. He's the Executive Director at the Brigham, and importantly, the Principal Investigator for REDUCE-IT. Joined by Nathan Wong, who is a colleague from UC Irvine, who has played a big part in preventive medicine and was the former president of the Cardiovascular Preventive Medicine Society. We'll then go to questions and answers. So I'm going to start with the next slide. So here we are today on what is International Women's Day, and this disease unfortunately affects men and women throughout the United States. Cardiovascular disease led to about 850,000 deaths annually a little while ago, and it's obviously slowly going up. COVID gave us 500,000 or a little over 500,000 deaths and gave us certainly a competition, but we expect that once COVID is starting to come down, then we'll resume to the standard cardiovascular death rate of under 1 million cases a day, but substantial, with additional costs that are estimated at $350 billion a year for these patients, which will peak or continue to go up in the next 10 years to about $1 trillion. Next slide. Next. So for this cardiovascular disease, we've got good therapy. We can reduce cardiovascular event rate by perhaps as much as 50%, but that leaves an additional 50% of those individuals that represent those 850,000 deaths each year in the US. The management of this disease has consisted of both behavioral and lifestyle changes, as well as risk factor management, lowering blood pressure, treating cholesterol with a variety of agents, antiplatelet therapy, management of diabetes, and in selected cases, revascularization, which can improve survival in some patients. Although these changes and therapies are proven benefit with multiple trials on these entities, the population with cardiovascular disease still remains at high residual risk of cardiovascular events, with about 50% or more of these individuals still having events at this time. And it is for these patients that we are here today to look at and explore other types of medical management, whether they be marine oils and other oils as supplements, whether they are new therapies on reducing lipid absorption, altering lipid metabolism, using RNA and other areas, and other techniques to remove lipids. These are all important strategies. We need additive ways because of this significant residual risk that we'll be discussing today. Next slide. And with that, we're proud to have today with us Deepak Bhatt, shown here, with multiple degrees in a variety of areas, who is the executive director, as I said, of cardiovascular programs at the Brigham and is professor at Harvard Medical School. And suffice it to say that Deepak has superb training in multiple institutions, has multiple publications across the board in cardiology, and hundreds of awards for his leadership in cardiovascular disease. He is well recognized as not only a national leader, but an international leader in cardiovascular disease. And we're happy to have this expert in cardiovascular disease address an important area, as he was the principal and investigator for a important REDUCE-IT trial. We're happy to have Deepak here today to present on this residual risk reduction. Deepak.
Well, terrific. Thank you so much for having me. So let me go ahead and get started. I'm just going to share my screen here. And if you can just confirm, are you able to see my screen well?
Yes.
Good. And are you able to see it sized appropriately for your screen?
Yes.
Yes.
Okay, very good. And can you hear me well?
Yes.
Yes.
All right, great. Well, I'm going to go ahead and get started. I think I've got about 45 minutes or so. And I'm going to be covering a lot of material here, but I'll try to go at a pace that hopefully makes it clear. Before getting started with the actual presentation, let me just share with you disclosures, and what's relevant to today's talk is research funding from Amarin that is paid to Brigham and Women's Hospital for my role as the REDUCE-IT study chair. REDUCE-IT was funded by Amarin and studied the drug Icosapent Ethyl. And I may make comments about Icosapent Ethyl at times that are off-label or investigational. Before getting started too specifically about reduced Icosapent Ethyl, I do think it's worthwhile to step back and realize that there's a lot of different ways of addressing risk. Of course, everyone's familiar with secondary prevention, that is treating disease, or primary prevention, treating risk factors. But then, of course, there's primordial prevention, trying to prevent the development of risk factors through healthy lifestyle. And that is particularly relevant as we're talking about patients with elevated triglycerides, because there's a lot that can be done in terms of lifestyle, that is maintaining an ideal body weight or losing weight as needed, and also avoiding things like excess alcohol intake. So there are a lot of health behaviors that can contribute to overall good cardiovascular health, even more pertinent when one is discussing triglyceride elevation. But among risk factors, before I get to triglycerides, let's talk at least a little bit about LDL cholesterol. There's no question now that LDL cholesterol is a direct causal risk factor, and the data are quite strong that in people with elevated cholesterol, they should be treated. And exactly who should be treated and when depends on how high the cholesterol is and what their background level of cardiovascular risk might be. But the concept that's shown on this slide is that of cholesterol years. Much like we think about tobacco and pack years of history and risk, the same concept should apply to cholesterol, where an elevated cholesterol for a long time is ultimately going to predispose to atherosclerosis. So we want to interrupt this cycle early, much as we would address pack years of tobacco use. All right, well, that's all I'm going to say about LDL cholesterol. Let me now shift to triglycerides. It's been a long-standing debate whether they are causal risk factors or not, but the weight of evidence now has swung to pointing to triglycerides as causal risk factors. And really, I mean triglyceride-rich lipoproteins being causal risk factors, not just innocent bystanders, but participating in the atherosclerotic process directly. Here are some Mendelian randomization data that support that contention that triglyceride-rich lipoproteins are indeed causal. In this particular analysis from the University of Cambridge, what was shown was that LDL cholesterol is a part of the causal pathway towards atherosclerosis, but so are triglycerides. Where, again, when I say triglycerides, I really mean triglyceride-rich lipoproteins. So both are independent risk predictors, but also independently on the causal pathway to atherosclerosis, to the extent you believe Mendelian randomization studies. So the implication would then be lowering LDL cholesterol and lowering triglycerides would each independently lower cardiovascular risk. But this analysis went one step further to show that the degree of lowering matters, of course. That is, one would have to lower triglycerides by a lot to get the same effect as lowering LDL cholesterol by an intermediate amount. So what that means is if a drug is going to lower cardiovascular risk, it would have to lower triglycerides by a very large amount to produce the same sort of risk reduction that would be afforded by lowering LDL cholesterol by a much lesser amount. As far as hypertriglyceridemia goes, there's lots of different therapies that are out there. Some are old, some are new. Among the old therapies, omega-3 fatty acids at a high dose are at the top of that list, but there are other things like fibrates, for example, as well, that lower triglycerides. So it's not just omega-3 fatty acids. But there are also newer compounds that I'm not going to spend much time talking about, but approaches targeting RNA to lower triglycerides. And these, if they're found to be safe and not have off-target toxicity, could be very effective ways of lowering triglycerides and any associated cardiovascular risk. They lower triglycerides by 50, 90, 100% or more, depending on the specific compound. So if that Mendelian randomization work is correct, and if this class of compounds doesn't have some off-target toxicity, well, then we should see a class of compounds that reduces triglyceride-rich lipoproteins and also reduces cardiovascular risk through that direct pathway. Now, as far as the omega-3 fatty acids go, I mentioned that they can lower triglycerides when used at high doses. They also appear to have anti-inflammatory effects, as this small study shows. This was something I had done at Cleveland Clinic with colleagues from there, where we showed an effect on C-reactive protein of omega-3 fatty acids. But it's a small study, like a lot of the studies in the omega-3 fatty acid literature, small, interesting, provocative, but not definitive. However, in terms of clinical trials, I think the data are definitive. That is, multiple different randomized trials of mixtures of omega-3 fatty acids showing no benefit. For the most part, what was represented in this meta-analysis are low doses, by that I mean about a gram or so a day, of mixtures of omega-3 fatty acids, predominantly EPA, or icosapent acid, and DHA, or docosahexaenoic acid. And these mixtures at about a gram a day were not effective in reducing cardiovascular risk. As you can see in this meta-analysis, the rate ratio is essentially 1, or 0.97, pretty close to 1. So no benefit here. Now, let's go to the most recent trial of a mixture of omega-3 fatty acids, the STRENGTH trial, which examined 4 grams a day of a mixture of EPA and DHA. And here as well, it was still the same message, no benefit. In fact, the Data Monitoring Board terminated the trial for futility. And here is the AMAME trial, also quite recent, also examining a mixture of omega-3 fatty acids, EPA and DHA, at an intermediate dose, 1.8 grams a day. But same message, same bottom line, another negative trial. So whether it's low, high, or intermediate doses of mixtures of omega-3 fatty acids, the data have been pretty consistent, not showing cardiovascular benefit for the trial's primary endpoints. Of course, if you look at subgroups or secondary endpoints, there are some signals of positivity, but overall, a bunch of negative trials. So what's been going on in the field of omega-3 fatty acid is nothing short of a revolution. Not sure that every doctor knows that, but in fact, there is a revolution going on. And it helps to understand a little bit about omega-3 fatty acids. I don't think this is something that people learned in school so much. Much like we learned the Krebs cycle, I think in the future, medical students will learn this pathway, but what they learn might be very different from what I showed. This is from a recent editorial in the Journal of the American College of Cardiology. Dr. Budoff, prominent Californian, who's a cardiologist, was a co-author on this, along with Preston Mason, who's a scientist here in Boston that's doing a lot of pioneering research in omega-3 fatty acids. And what we have here is a figure showing how different omega-3 fatty acids are converted from one another. So here at the top is alpha-linolenic acid, or ALA. That can be derived from vegetarian or indeed vegan sources, such as chia seeds or flax seeds or walnuts. So that is a natural vegetarian or vegan way of getting omega-3 fatty acids. There are a bunch of steps here where that's converted to EPA, or icosapent acid, another omega-3 fatty acid. There, that can be obtained from marine oily fish. And then a bunch of other steps, and that's converted to DHA, or docosahexaenoic acid. Again, that can essentially only be obtained from marine oily fish or other forms of seafood. And then these omega-3 fatty acids are converted into a bunch of other things, including potent anti-inflammatories. But you'll see EPA and DHA are converted into different types of downstream mediators, not the exact same. So it's not fair to say EPA and DHA are just, omega-3 fatty acids and they're all created equal. No, they're quite different. To say EPA and DHA are the same would be a lack of understanding of omega-3 fatty acids. They are different in terms of the length of carbon chains here, as you can see, in terms of the number of double bonds. And does that matter? Well, of course it matters. It would be analogous to someone saying testosterone and estrogen are both hormones and therefore they're the same thing. No, of course they have different biological effects downstream, and it's the exact same situation with EPA and DHA. Yes, they're both omega-3 fatty acids, but they're as different as estrogen and testosterone are among hormones. Now, the steps that I've shown here are based on our best current understanding. I imagine in years to come that this figure will evolve because our understanding of omega-3 fatty acid biology is rapidly evolving. Now let me shift to talk about Icosapent Ethyl, a prescription medication that is made from EPA, or icosapent acid, the omega-3 fatty acid. So hopefully that makes the terms a bit more clear. And the Icosapent Ethyl is then prescribed, it's ingested, it's converted via lipase to icosapent acid, and it's got an ethyl group that is there. Icosapent ethyl is actually a highly purified ethyl ester of EPA, or icosapent acid, but in the body it's converted to EPA, and then EPA does its thing. And again, as I mentioned, EPA itself results in the formation of several downstream mediators. Now let's review the data for EPA, or icosapent ethyl, which was studied in the large JELIS trial published in The Lancet in 2007. So this was a randomized trial of icosapent ethyl versus control, no placebo, a so-called open label randomized trial. And there was a significant 19% relative risk reduction that was statistically significant, so a positive trial. It was 80% primary prevention patients. As I mentioned, it was all Japanese patients. 69% were women. The average triglycerides were about 150 milligrams per deciliter. So about half the patients at baseline had normal triglycerides. The LDL was elevated at baseline. Patients were started on statin, mostly sort of lower potency statins at the time, but nonetheless treated with statins, and nevertheless a 19% relative risk reduction, only a 5% reduction in triglycerides because half the patients had normal triglycerides at baseline. So this was not a triglyceride lowering trial. This was a cardiovascular risk reduction trial. And it was positive with benefits that were consistent in the primary and secondary prevention cohorts. This is a small trial, only 240 Japanese patients post PCI, or percutaneous coronary intervention. I'm sort of mixing big and little trials here for the sake of completeness, but this is really a small trial. I wouldn't normally pay much attention to it, but nevertheless, it's interesting that it was positive, showing a significant reduction in major adverse cardiovascular events in patients randomized to EPA versus randomized to control on top of background statin therapy with pitavastatin. And interestingly, though obviously way underpowered, there was also a p-value of less than 0.05 for cardiovascular death in favor of icosapent ethyl versus control. Now, here is another trial from Japan, CHERRY, 193 patients who have undergone PCI who got an IVUS or intravascular ultrasound, taking a look at the plaque from the inside in patients randomized to icosapent ethyl plus statin versus statin alone, showing just by 6 to 8 months a significant difference in the rates of plaque progression. Indeed, the author said plaque regression with EPA versus control. So yet another positive trial of icosapent ethyl, albeit an imaging study. This wasn't a cardiovascular event trial. And then most recently in the series of mechanistic trials that have been done is Evaporate. And what's shown here is work led by Dr. Budov, examining the effect of 4 grams a day of icosapent ethyl versus placebo, now a proper placebo-controlled trial in Western patients, really in US patients. And what we see is that icosapent ethyl significantly affected multiple different measures of plaque volume and composition at this 9-month interim analysis, though the trial went on because the pre-specified primary endpoint wasn't significantly reduced. So the trial went on to its planned completion at 18 months, and there was seen significant differences, not only in the primary endpoint, but multiple different measures of plaque volume, plaque composition, rates of plaque progression. So this really corroborated what was seen in CHERRY, but now using non-invasive CT angiography instead of intravascular ultrasound, what was used in CHERRY, and now in a Western population, and now with a proper placebo control. So 2 different imaging studies, CHERRY and Evaporate, both basically showing the same thing, that icosapent ethyl helps prevent plaque progression and alters the composition of plaque in ways that are favorable. And this chart compares different changes in total plaque volume. I don't know if you can see my cursor, but I'm pointing to total plaque volume. You see here that in the icosapent ethyl arm, it was decreasing. In the placebo arm over time, it was increasing. And this is in general what we see across a variety of different trials. That is, if you're not actively intervening, even if patients are being treated with statins, you typically do see over time on CT angiography progression of plaque. And the editorialists conjectured, can EPA evaporate plaque? And indeed, it does seem like in some patients, it does lead to plaque regression. And plaque regression is one of many potential benefits of EPA. I alluded to the anti-inflammatory benefits. There are also benefits on endothelial function by enhancing nitric oxide bioavailability. Dr. Preston Mason's done a lot of experiments that show this. Favorable effects on cholesterol crystalline domain formation, decreases in oxidation of LDL, effects on platelet activation and thrombosis in general. So there's really a host of different things. For the sake of time, I can't go through all the different basic science and preclinical work supporting beneficial effects of EPA. As it turns out, and this is some more work from Preston Mason, there are different effects on cell membrane preparations of EPA, shown here stabilizing cell membranes, versus DHA, shown here disrupting cell membrane preparation. So just because something is an omega-3 fatty acid doesn't mean that its biological effects are the same. In fact, here in this particular experimental model, they are markedly different. And this might have implications then for what types of omega-3 fatty acids actually can lower cardiovascular risk. And to date, it seems like EPA is where the action is at. Speaking of EPA, it's been studied pretty extensively in the icosapent ethyl clinical program. I mentioned the JELIS and CHERRY trials and another small trial. Those 3 Japanese trials did all use icosapent ethyl, the same active ingredient as in the trials I'm about to review here. It was a different branded prescription medicine, but the same active ingredient of icosapent ethyl, which in the West was studied in the MARINE trial. Patients with triglycerides greater than or equal to 500 showing a significant reduction in triglycerides and therefore hopefully reducing pancreatitis risk. That led to FDA approval of icosapent ethyl. And since that time, there have been millions of prescriptions given to patients for icosapent ethyl to reduce triglycerides when they're in that very high range. Next came ANCHOR, which studied patients with triglycerides between 200 and 500. That trial was also positive, showing a significant benefit with icosapent ethyl. However, the FDA did not approve icosapent ethyl in that range of triglyceride elevation because they said Well, why would you treat triglycerides in that range? Presumably to reduce cardiovascular risk, more so than pancreatitis risk. Well, show us that the drug's actually reducing cardiovascular risk. Very logical conclusion, I thought. And fortunately, we had already started such a cardiovascular outcome trial, Reduce It, in patients with triglycerides between 150 and 500, really between 135 and 500, and an LDL cholesterol between 40 and 100 on statin therapy and adherent to statin therapy. So that was the Reduce It trial with over 8,000 patients. And just to get into the design in a little bit more detail, 8,000 plus patients, 70% of whom had established cardiovascular disease, could have been coronary artery disease, peripheral artery disease, cerebrovascular disease, or diabetes plus at least one additional cardiovascular risk factor. So secondary prevention or high-risk diabetes primary prevention, and triglycerides that were elevated and LDL that was controlled. So that's how patients got into the trial. So really quite generalizable findings, I think. Then the patients were randomized once it was ensured that they were adherent to their statin and on a stable dose. And once they'd received dietary counseling from their physician, they were randomized to Icosapent Ethyl, 4 grams a day, or to placebo. And then they were followed for an average of 4.9 years and up to 6.2 years. The primary endpoint was the first occurrence of MACE, that is cardiovascular death, non-fatal MI, non-fatal stroke, coronary revascularization, or unstable angina requiring hospitalization. So that's the overall trial design. The background medical therapy was excellent. A high use of antiplatelet therapy, dual antiplatelet therapy, where appropriate anticoagulation, ACE inhibition or angiotensin receptor blockers, beta blockers, and by protocol, everyone was supposed to be on a statin. So great background generic medical therapy. So we really wanted to show that on top of what could be done easily, cheaply, that the addition of Icosapent Ethyl further reduced cardiovascular risk. And that's what we showed. As you can see here, a significant reduction in the primary composite endpoint of cardiovascular death, MI, stroke, coronary revascularization, unstable angina, a 25% relative and a 5% absolute risk reduction, number needed to treat of only 21, highly statistically significant. The key secondary endpoint of cardiovascular death, MI, stroke, also significantly reduced. So not just overall MACE, but so-called hard MACE, the triple ischemic endpoint, also significantly reduced, also with large relative and absolute risk reductions. A consistency across multiple pre-specified subgroups for the primary endpoint, also for the key secondary endpoint, also including the 10% or so of patients with normal baseline triglycerides. A number of pre-specified secondary endpoints were reduced, significant reductions in death from cardiovascular causes, from fatal or non-fatal MI, from fatal or non-fatal stroke. So a variety of different ischemic endpoints, not just in combination, but in isolation, significantly reduced, with even a trend towards a reduction in all-cause mortality. That was time to first event. That's the usual sort of conservative way of analyzing data, looking at the time to that first MI or stroke or whatever the ischemic event is. Now what I'm showing you is a recurrent or subsequent or total event analysis, examining not just that first MI, but in that patient who had a non-fatal MI, that second event, maybe a stroke or a stent or a bypass surgery, or maybe a cardiovascular death. And as you can see, there was a significant reduction in first events. That was on this prior slide I just showed you, but also a significant reduction in second, third, and even fourth or more events as a discrete category was significantly reduced. So a large effect not on just first events, but recurrent events also. A large absolute risk reduction, over 500 events prevented in this population, and also a large relative risk reduction of about a 30 to 32% reduction in total events, depending on the exact definition of recurrent events analysis used. In fact, for the US FDA, we pre-specified the Anderson-Gill methodology, and there was a 32% relative risk reduction with a p-value of 10 to the minus 22. So very robust risk reduction. These are the same data, but in graphical form, showing time to first event that's the light lines, and total events, that's the darker lines. Red is placebo, blue is icosapent ethyl. And you can see that over time, there's a greater number of events accruing and also a larger benefit accruing. I should point out that this high-risk population excluded patients with acute events. So these weren't patients coming in with an acute MI or a stroke or getting a stent or something like that, or a bypass surgery. These were patients, some of them had that in their history, but these were stable outpatients who, despite dietary counseling, despite statin, had elevated triglycerides, in some cases low normal, that is a high normal elevation in triglycerides. So patients with high normal, modestly elevated triglycerides, that was what was driving this risk. So elevated triglycerides really are a good marker of high risk, as we've demonstrated in this trial and as multiple different studies have shown. Dr. Wong, I'm sure, will get into that in greater detail. So in this population of stable outpatients, albeit at high risk, as demarcated by elevated triglycerides, very large risk reductions in absolute terms, 159 events prevented for every 1,000 patients treated with icosapent ethyl for 5 years, including significant reductions in things like cardiovascular death, fatal or non-fatal MI, or fatal or non-fatal stroke, with no double counting of events. Let me shift now to discuss the side effect profile. That's obviously an important part in assessing any medication. And first of all, when we look at the overall tolerability and safety of the drug versus placebo, there's no significant difference. As you can see, all the p-values are negative. The rates are virtually identical in these two columns, if you can see my mouse pointing at them. And this is true if we use very sensitive definitions of adverse events, where 80+% of the patients in each arm have an adverse event. It's also true if we look at very sensitive, or rather very specific definitions, such as adverse events leading to death here in the bottom row, a bit over 2% in each arm. So whether it's a sensitive or specific measure of an adverse event, the rates are virtually identical. So overall, this drug was tolerated as well as and as safe as the placebo. We did note a significant increase in bleeding with icosapent ethyl versus placebo. This was increased from about 10% to 12%, but fortunately, no significant excess in bad bleeding like GI bleeding or GU bleeding or central nervous system bleeding or intracranial bleeding or fatal bleeding or hemorrhagic stroke. So it was largely minor bleeding that was increased. And this was the same pattern in patients on anticoagulants, on dual antiplatelet therapy, where we did not find any significant excess in the forms of major bleeding that I just mentioned. The other thing we noted was a significant increase in hospitalization for atrial fibrillation from 2% to 3%, and this was statistically significant. However, if we look at serious AFib here in the middle, it was 0.5% in each arm of the trial. So yes, there's an increase in hospitalization for AFib, but fortunately, it doesn't seem that there are really bad sequelae of AFib. And as you may recall, in the overall trial, there was no increase in stroke. Rather, there was a 28% reduction in stroke that was statistically significant, with benefits that were consistent in the subgroup of patients who had atrial fibrillation at baseline, or even those that developed atrial fibrillation during the trial. Now let me share with you some secondary analyses from REDUCE-IT. We examined patients by tertile of baseline triglyceride, and as you can see, there's a consistent reduction in ischemic events, even in the lowest tertile of triglycerides. So this argues that this isn't just a triglyceride story. Yes, we happen to enroll patients with elevated triglycerides. Yes, that conferred a high risk of future ischemic events, but it's probably not the case that the majority of benefit from this drug is from lowering triglycerides. It happens to lower triglycerides. That's probably useful if the triglycerides are really elevated in a pancreatitis range. But with respect to reducing cardiovascular risk, that probably isn't so contingent on the triglycerides being elevated. Now, if we just look across a variety of different trials over time, well, there are lots of things that can lower triglycerides. And some of those also show reductions in cardiovascular events. If we go to the VA HIT trial, for example, maybe some of you remember that with gemfibrozil, fibrate, there was a significant reduction in cardiovascular events with gemfibrozil, but that trial largely predated the statin era. You could also look at things like Dietary Prevention, where an omega-3 fatty acid did reduce cardiovascular events, modestly so, but again, largely predating the statin era. So really with statins, you've got GELIS, and with good LDL control, you've got REDUCE-IT showing a benefit of Icosapent Ethyl versus no Icosapent Ethyl. In the case of GELIS, an open label trial with no placebo. In the case of REDUCE-IT, a double-blind trial with a placebo. Now let me share with you some mechanistic data from REDUCE-IT EPA. Here we've examined on-treatment serum levels of icosapentaenoic acid, or EPA, and the association, the correlation with the primary endpoint, the key secondary endpoint, cardiovascular death, and even total mortality. And what we find in all cases is a highly statistically significant correlation between higher levels of EPA and lower rates of these different events. So it does appear there's some sort of threshold effect where you have to get above maybe 150 or 170 or so, perhaps, before there's a bit of plateauing. So it is the case then that lower doses of EPA that don't produce this level of elevation probably aren't going to provide cardiovascular benefit. These relationships were also seen for the endpoints of MI, stroke, coronary revascularization, and unstable angina, with benefits that seemed consistent in those with secondary or primary prevention type indications to get into the trial. And now if we compare across trials, STRENGTH, GELIS, and REDUCE-IT, well, first of all, we see that at baseline in the largely Western STRENGTH and REDUCE-IT trials, patients start off with levels of EPA of about 21 or 26 micrograms per milliliter. And we see in STRENGTH, they get to about 90 or so, whereas in REDUCE-IT, they get to about 170 or so. And interestingly, where they end up in STRENGTH with a mixture of DHA and EPA is where in GELIS, in Japanese patients, they start, probably because they've got a diet higher in fish intake than in the Western world, they're starting where STRENGTH ended. But in GELIS as well, they're ending where we ended in REDUCE-IT with an EPA level of about 170. So if there is some sort of threshold effect, yes, the preparation used in STRENGTH did raise EPA levels, but probably not enough to make a difference. Even say in the highest tertile of STRENGTH, where patients got higher levels of EPA, it probably still wasn't sufficient to cross the threshold needed for benefit. And beyond just levels, the formulation probably does matter. I think Dr. Wong will get into this in a bit, but formulations such as the one used in STRENGTH or dietary supplements are subject to oxidation, and that can negate any benefit of the EPA that might have otherwise been provided. It's very different with Icosapent Ethyl in GELIS or REDUCE-IT, which is produced, packaged, shipped in a way that prevents oxidation. Because once omega-3 fatty acids are oxidized, they likely lose their benefit, might even become toxic. Okay, let me move on now to REDUCE-IT diabetes. Here we examined patients in the pre-specified subgroup of those with diabetes, mixing primary and secondary prevention, finding significant benefits in the primary and key secondary composite endpoints, true for total events in the darker lines and first events in the lighter lines. Again, red is placebo, blue is Icosapent Ethyl. But in all cases, you can see large relative and absolute risk reductions. Also, look at how high the event rates even are in the treated arm, showing the double whammy afforded by having someone with both diabetes and elevated triglycerides, despite dietary counseling, despite relatively good glycemic control, where the average hemoglobin A1C was 7, despite mandated statin therapy with documented adherence. Despite all this, if the triglycerides are elevated, that patient is destined for problems. Okay. Now let me move on to REDUCE-IT Revasc. This examined the endpoint of coronary revascularization. And what was seen here for Icosapent Ethyl versus placebo, again, a large absolute large relative reduction in the need for coronary revascularization in this double-blind trial. Furthermore, the time to benefit of revascularization was much earlier than we had realized when we first examined the data. Statistically significant, or I should say consistently statistically significant, by 11 months. In fact, the hazard ratio is well below 1 soon after randomization. So this tells me there is an early benefit of icosapent ethyl. And this matches what was seen in the CHERRY trial with intravascular ultrasound, where by 6 to 8 months, there was a significant benefit of icosapent ethyl. Personally, I wouldn't have even looked that early on an IVUS study. I'm not sure why they did. Most IVUS studies go longer, but I'm glad they looked because they found and showed an early benefit, and it matches the nice work from Dr. Budoff in Evaporate, where there was also an early benefit with multiple markers of plaque that were influenced by only 9 months. So that 6 to 8 months in CHERRY, 9 months in Evaporate, 11 months in Reduce-It Revasc all line up beautifully, supporting an early benefit of icosapent ethyl. And significant benefits in elective, urgent, and even emergent coronary revascularization, each significantly reduced with icosapent ethyl versus placebo. And not only was the need for percutaneous coronary intervention reduced in this double-blind, randomized, placebo-controlled trial with independent adjudication of events, the need for coronary artery bypass grafting was also significantly reduced. So that tells me that it was really substantial plaque that was being altered, influenced, perhaps reduced with icosapent ethyl versus placebo, such that there was less of a need for bypass surgery in this blinded trial. How does Reduce-It compare with other trials? Well, you can see you'd have to go back in time to the 4S trial to see this sort of reduction in revascularization or other major adverse cardiovascular events. And of course, the 4S trial was a trial of statin versus placebo. Reduce-It is a trial of icosapent ethyl versus placebo, but on top of statin. So it's not like 4S where it was just the drug versus placebo and no background therapy. Here, the background therapy was mandated statin use, so with good LDL control documented. So this, I think, really is a substantial advance in the field of cardiovascular risk reduction. Now let me share with you Reduce-It PCI. This is a subgroup of patients who in Reduce-It had a history of prior percutaneous coronary intervention. So that's different from what I just showed you, where Reduce-It Revasc looked at the endpoint of revascularization in the entire trial, all 8,000 patients. Here we're looking at the 3,400 patients with a history of PCI. But what we find is a significant reduction in 5-point MACE favoring icosapent ethyl versus placebo. Relative risk reduction of 34%, an absolute risk reduction of 8.5%, a number needed to treat of only 12. So in those patients who have a history of PCI, we see a significant benefit. And again, the trial excluded those patients most likely to benefit. So for example, we didn't include patients, coming right out of the cath lab, for example. These were patients with a history of PCI. Had we started the therapy earlier, we would have probably gotten an even larger benefit, but we didn't include such patients. And that was the primary endpoint. Here's the key secondary endpoint of CV death, MI, stroke, again, in those patients with a history of PCI. And once more, large relative, but also large absolute risk reductions, a 34% relative, 5% absolute risk reduction, and an NT of only 19 for hard MACE. This is CV death, MI, stroke we're talking about. All right, now let me share with you Reduce-It CABG. And this was, again, the subgroup of patients with prior CABG. What we see here for the primary endpoint in these 1,800 patients is once more significant relative and absolute risk reductions favoring icosapent ethyl versus placebo. And once more, these weren't patients coming, right off the bypass pump. These were patients with a history of CABG. Had we enrolled patients right out of CABG, we might have seen even larger benefits. And now our patients with CABG, but we're examining the triple ischemic endpoint, the pre-specified key secondary endpoint of CV death, MI, stroke. Once more, large reductions, a 31% relative, a 6% absolute risk reduction. Events reduced from about 27 to 20% or so, highly statistically significant. So In patients with prior CABG, prior PCI, very easy to identify these patients, large, substantial reductions in risk. So now let me start to wrap up here so that I stay on time. It's been a long road to approval with multiple studies, some that were triglyceride focused, such as Marine and Anchor, others that were cardiovascular risk focused, namely Reduce-It, but Jealous in the past with another branded version of Icosapent Ethyl. Multiple different guidelines have incorporated and endorsed the use of Icosapent Ethyl in a Reduce-It-like population. I think that Dr. Wong, Dr. Bommer are going to get into the details of some of that, so I'm not going to get into the specifics, but multiple different groups, such as the American Diabetes Association, the European Society of Cardiology, have endorsed the use of Icosapent Ethyl in appropriate patients. And not only the main paper, but now multiple different subsequent analyses have corroborated the robustness of the Reduce-It data set. In terms of regulatory approval, there was a unanimous vote by the advisory committee at the FDA to approve Icosapent Ethyl in a Reduce-It-like population. The FDA formally did approve Icosapent Ethyl, not only for patients with elevated triglycerides above 500, that was already there, but then for patients that were Reduce-It-like, that happened in December of 2019, and then shortly thereafter, Health Canada also approved. It's kind of a shame that those approvals occurred right before the pandemic. I think that's really hurt the uptake of the drug among physicians, because the usual sort of, I hate to say it, but what usually moves practice in US medicine is detailing. But that usual sort of detailing where the drug rep comes in and makes the pitch to the doctor and their staff, that really hasn't happened. And I think that whether you think that's a good idea or not, that sort of detailing, that has actually hurt the uptake of the drug. But nevertheless, the strength of the data continues to grow with subsequent analyses, and other regulatory agencies are reviewing the data. So it's approved, as I said, in the US and Health Canada based on Reduce-It. The European Medicines Agency is reviewing the data and should opine, I think, in April is what the projections are. CHMP, that's the European agency that reviews the data, has already opined favorably. So hopefully that bodes well for EMA approval. There's also regulatory review going on in China. That's very exciting. There's actually lots of people in China that would fit into the Reduce-It inclusion criteria. So we'll see what the Chinese regulatory agencies say. But my point being that the drug is poised for approval in multiple regions of the world beyond just the US and Canada. And then finally, how does Reduce-It fit into the larger picture? Well, I think subsequent speakers are going to get into this, but just to give you my top line thoughts, there certainly are important trials like Prove It and Improve It done by my colleagues here in Boston, Chris Cannon and Dr. Braunwald, among others, showing the value of LDL control, incremental LDL control with statins or ezetimibe, providing additional cardiovascular risk reduction. And now we have Reduce-It, a separate pathway in patients with controlled LDL to further reduce their cardiovascular risk, with relative and absolute risk reductions that are even larger than what was seen in practice-changing trials, such as Improve It and Prove It. And therefore, I do think now the onus is on us to really implement these findings and improve the care of patients. Now, I have focused on Reduce-It and on Icosapent Ethyl and on EPA, but of course, there's a lot more to reducing residual cardiovascular risk than just one drug. And personally, I think it all starts in patients that have cardiovascular disease or are at very high risk of it with a plant-based diet, to the extent the patient can do that, in terms of a diet that is high in whole fruit and vegetable and whole grain intake, and lower absent in red meat. I think in appropriate patients who can tolerate it, high intensity statin therapy is also indicated. And then I think it's a matter of seeing what is the major driver of the residual risk. Is it cholesterol that's still out of control? Is it potentially things in the future like Lp(a), where we might have drugs to address that? Is it inflammatory risk? Is it thrombotic risk? No easy way of assessing that right now. Or is it triglyceride-associated risk? And if it's triglyceride-associated risk, then potentially reduce it is now an option with Icosapent Ethyl. But really from reduce it, I think we've learned in the EPA analyses, we've learned that it isn't just triglycerides, but it's really other things that are driving the benefit through EPA, things that we've not fully characterized, but some anti-inflammatory effects, some anti-thrombotic effects. We know that because there was bleeding in the trial. And it's this combination of anti-inflammatory, anti-thrombotic, triglyceride lowering, and other effects that probably account for its marked cardiovascular benefits. And it's important to realize the STRENGTH trial did significantly reduce triglycerides, but did not significantly reduce cardiovascular risk. So not all drugs that reduce triglycerides are going to reduce cardiovascular risk, really. Every drug has to be studied, and we can't generalize and just say, oh, everything's in the same class, and therefore everything's going to be the same. Much like we have learned with GLP-1 agonists, they're not all the same. They all reduce glucose, but they don't all reduce cardiovascular events. Different drugs are different. And finally, I'll just say that the profound reductions in first and total cardiovascular events with Icosapent Ethyl in the REDUCE-IT trial should usher in a new era in dyslipidemia therapeutics. And finally, I focused on one potential pathway towards cardiovascular risk reduction, but of course, there's a lot we need to do. And it all starts with lifestyle modification and then treatment of risk factors with medical therapy when appropriate. And certainly in those in the secondary and tertiary prevention universe, that often involves polypharmacy. Well, thank you very much for your attention. It's really been a privilege to be able to speak to you. I hope this discussion of REDUCE IT and putting it in a larger context was useful to you. Thanks once again.
Well, thank you very much, Deepak. That was an outstanding presentation. We're going to be transitioning to Nathan's slides, but while we're doing that, Evelyn Stock, who is our international co-chair, had a quick question for you while Nathan is preparing his slides. Evelyn?
Thank you, Bill. Hi, Deepak. Thank you for bringing us up to speed in these new standard of cares for our patients with cardiovascular disease and showing us probably what's the biggest development in secondary prevention since statins. You showed us how to improve it, prove it, and reduce it, right? I have a question about now that we have this new standard of care, and what would be your message to us as we try to bring down cardiovascular disease as a general rule? Should we be pushing to get this drug to our patients, and how?
Yeah, it's a terrific question. I mean, I do think the data are strong, and obviously as the PI, I might feel strongly about the data. But even putting that aside, multiple different folks, the US FDA analyzed the data from the raw data, so did Health Canada. That's going on with the CHMP in Europe. Multiple different guideline writers from the American Diabetes Association, the National Lipid Association, the European Society of Cardiology, European Atherosclerosis Society, the American Association of Clinical Endocrinologists, the Brazilian Cardiology Society, the Japanese. There have been multiple different folks that have looked at the data and thought that it really should influence patient care. So I agree with that. And I think the major challenge is implementation science, which is often the case. I mean, we could say statins or generic ezetimibe are still quite underutilized. And why is that? Yes, sometimes it has to do with patient tolerance, but sometimes the patient hasn't even been offered the drug. So, it does take a while for data to be disseminated. And I think, that's part of what events like this do, get the word out there about data. But beyond just raising awareness and getting the word out, I think, another challenge is cost. I think Dr. Bommer is going to speak a bit about that. I mean, the drug has been found to be cost effective, as he'll review, but that's cost effective at a societal level. Of course, all a patient cares about is their out-of-pocket costs, understandably. And, that can be a bit of a challenge, but I think, we've got to advocate for our patients and, for patients that really are at high risk, like we sometimes struggle to get them on a PCSK9 inhibitor. with the pre-authorizations and so forth. Got to fight, the same sort of battles here. And, for patients where that's not going to work, go to the company with the different sort of options that are out there to get the drug at a reduced cost or free for indigent patients. So, I think those are the real challenges that fall upon us. So, the science, I think, is terrific, but it means nothing if there's not implementation science.
That's right. Well, thank you. And as we get out of this COVID mess, we'll probably have more opportunities to spread the word. Thank you.
I think you're right, or at least I should say, I hope you're right.
I hope so. Thank you again.
Well, thank you very much. We're going to move on to, that was great and shows the effectiveness of this, the potential for the United States and globally is going to be explored by our next speaker, Nathan Wong. Nathan is the director of the Heart Disease Prevention Program and the Division of Cardiology at UC Irvine, president of Inter-American Heart Foundation, and past president of the American Society for Preventive Cardiology. And I should state, an old colleague that I have known for many years and worked on NIH trials for. So we're delighted to have Nathan, who is, again, an expert on this, presenting for the population impact for these new interventions. Nathan.
Great. Well, thank you very much. It's a real pleasure to share this program with you, Dr. Bommer, and with you as well, Dr. Bhatt. And want to just preface my talk by congratulating you, Deepak, on all your fantastic work with the Reduce It trial. It's certainly a game changer, and as many of us agree, was really one of the top stories and studies in cardiovascular medicine over the last decade, and it has really moved the needle as to how we can address this residual risk problem. So what I'm going to be doing in the next 40 minutes or so is first I wanted to revisit some of the mechanisms regarding Icosapent Ethyl therapy, and then try to frame it within the current prevention guidelines. So kind of where does it fit, and then also what are some of the other emergent therapies that are important for addressing this residual risk issue. And then finally, get into some work that we did and what I was originally asked to talk about, which was the population-wide impact that may be possible for cardiovascular disease prevention with respect to Icosapent Ethyl therapy. So these are my disclosures. So we're first going to kind of review what might explain the benefit seen in Reduce It, but not seen in other trials of fish oil therapy. So as Dr. Bhatt nicely pointed out, Reduce It and Jealous were the only omega-3 fatty acid trials to show cardiovascular outcomes benefit beyond statin therapy. And these, of course, involved Icosapent Ethyl therapy. Other trials, particularly those involving DHA and EPA combinations, failed to show benefit and really involved amounts of EPA therapy much lower than that used in the Reduce It trial. So let's briefly re-review what are some of the characteristics of EPA that differ from that of DHA, and how might, and is it really possible to use dietary supplement omega-3 products instead? So we'll briefly touch on these issues before launching into the guidelines, which I think will be helpful since we have a very multidisciplinary group today. I think, as was pointed out earlier, we have a number of omega-3 fatty acids, both plant as well as seafood derived, but really only two as have been discussed during this program, EPA as well as DHA are effective for triglyceride lowering and have been the subject of numerous clinical trials. It's important to remind ourselves that the American Heart Association and other groups recommends at least 2 servings of fish per week, particularly fatty fish such as salmon, mackerel, herring, trout, sardines, and albacore tuna. A serving is actually only about 3.5 ounces. Usually when I consume salmon, I consume 8 ounces at once. That gives me that 2+ servings a week and supplement it with other seafood as well. Now, EPA and DHA are available in several forms. We're going to talk about the fish oil supplements a little bit more. Already discussed by Dr. Bhatt very nicely were some of the trials that involve combinations of DHA and EPA, as well as, of course, the Reduce It trial that involved an EPA-only prescription product. Now, there are numerous potential mechanisms, and several of these have already been touched on, but I think it's important that we reinforce them. And these really go beyond the triglyceride lowering properties of omega-3 fatty acids. So we really have to think of these as, and in particular, Icosapent Ethyl, as not just a triglyceride reducing agent. Okay, just like we don't think of statins anymore as just LDL reducing agents. These are cardiac risk reducing agents. So very, very important in the case of Icosapent Ethyl. And so what was also discussed, and I'm going to show you some data, are the anti-inflammatory effects, this co-resolving mediator effect, membrane stabilization. There's also anti-thrombotic and some other effects as well. This slide was already shown, but I think it's important to show it again. We need to understand that actually EPA preserves membrane structure and normal distribution of cholesterol, thereby helping EPA inhibit lipid oxidation and resultant cholesterol crystal formation, whereas DHA actually tends to disorganize the cell membrane by increasing membrane fluidity, and DHA tends to have reduced antioxidant activity due to this lipid disordering effect. There is also something called resolvins that are derivatives of omega-3 fatty acids, and these actually are synthesized during the acute inflammatory response, but they promote the resolution of inflammation. And EPA generates what are called E-series resolvins, and DHA generates D-series resolvins. We've already talked about how EPA can, and we're going to show another slide in a minute here, how it can reduce oxidation of ApoB containing lipoproteins much more so than DHA, as well as maintaining cell membrane integrity, so thereby decreasing fluidity, whereas DHA increases cell membrane fluidity. This interesting slide, and I must say that Preston Mason, also at Harvard with Dr. Bhatt, has really done the lion's share of the work in sorting out the different mechanisms of EPA and DHA. And what was shown here was, you can see, and these are the different, and remember that ApoB particles are the actually atherogenic lipid fractions. So this includes small dense LDL, LDL or low density lipoprotein, as well as VLDL or very low density lipoproteins. And what EPA can be shown to do is it actually retards oxidation of small dense LDL as well as LDL and VLDL for at least 4 hours. But you can see that this process is greatly attenuated after the first hour or so by actually DHA. So DHA is not nearly as useful in preventing oxidation of these atherogenic lipid particles. Also, as mentioned, was effects on inflammation. So we've long known, for example, that statins will lower C-reactive protein levels on the order of about 20 to 25%. EPA also lowers CRP by about the same amount, and the combination, of course, you get a much greater reduction in C-reactive protein. Now, this can be contrasted by the combination of EPA and DHA, which has essentially no effect on CRP. If you combine ezetimibe and statins, as well as also the newer bempedoic acid we're going to talk about in a little bit, these also do tend to lower CRP. Now, fish oil is consumed by about 20% of our high-risk patients, as demonstrated in this actually Gould registry. So this is a very common therapy that is used. However, unfortunately, much of the consumption is due to dietary supplement fish oils. And it's very, very important that both healthcare providers and the public understands that there's no over-the-counter omega-3 products that are FDA regulated, but non-prescription. And dietary supplements have very minimal, if any, FDA oversight, and therefore are not recommended to treat disease. However, unfortunately, manufacturers, despite the lack of clinical trials, oftentimes make certain health claims. So this, of course, influences the public about purchasing these and not realizing that many of these claims are not backed by good science, like the REDUCE-IT trial. One can see here that a leading dietary fish oil supplement can contain a third or more of the content being saturated fat. So why on earth would you want to give your patients a product that contains saturated fat? And if you consume enough of these capsules to get enough EPA, you're going to be consuming as much saturated fat as maybe in a hamburger. And I think Dr. Bhatt made that comment once in one of the talks I heard from him before. So, so this is a big problem. You have a lot of impurities, you don't have much EPA, and you also, instead of consuming 4 1-gram capsules of the prescription product, you would have to consume a lot more. And if you take krill, you would have to consume a lot more as well. But these do not have the scientific evidence. So we really have to remember that that therapies we use in cardiovascular medicine have to be based by randomized clinical trial evidence. So we've talked about how there's distinct differences between marine omega-3 fatty acids, EPA and DHA. We talked about the membrane stabilization and fluidity issues, the impact of resolvins, as well as the inhibition of oxidation is very different between EPA and DHA, as well as anti-inflammatory effects. So, and very important again is that we do not have randomized clinical trials to show that dietary supplements work. So why would you waste your time and your money with something that does not have the scientific evidence for reducing ASCVD risk? So let's move on to current prevention guidelines and implications of newer therapeutic options. So just to remind everybody that our nutrition recommendations over the past 7 or 8 years have really focused on dietary patterns. Okay, so this is very different from when I first got into this field in the 1980s, when we had the AHA step 1 and step 2 diet, and you were told how many % of total calories of this and that you should be consuming. Now it's really based on a pattern that is a Mediterranean or DASH type diet, emphasizing fresh fruits, vegetables, and whole grains, increased fiber, and reduced sugar intake. There are some general guidelines about how much fat and saturated fat, but really the focus is on a dietary pattern, regular fish intake, reduced sodium, and really eliminating processed and pre-prepared foods. And the best evidence, of course, stems from a Mediterranean diet. The PREDIMED study is probably the best example of this. Remember, this was a primary prevention trial of over 8,000 high-risk patients with either diabetes or multiple risk factors. And it showed a Mediterranean diet supplemented by extra virgin olive oil or nuts reduced the cardiovascular endpoint by 31% in the olive oil and 28% in the nuts group. No significant difference in total mortality. We know that trans fats, of course, is the most harmful fat of them all. These have largely been removed from the food supply, but you do have to be conscious of things like partially dehydrogenated vegetable oils when you read the ingredients of every package the way I do when I go to the supermarket. That's why I enjoy the supermarket so much. I can look at all these numbers and things. Saturated fat, of course, also can have a negative impact on total mortality, whereas monounsaturated and particularly polyunsaturated fat, including the omega-3s, have a beneficial effect on reducing total mortality. Physical activity guidelines generally focus on 30 minutes or 150 minutes a week, but ideally 30 minutes a day, 5 days a week of moderate to vigorous intensity physical activity. And most important thing is that the patient chooses what's enjoyable to them that they can sustain for a lifetime. Now let's get into risk assessment, because remember that assessing your patient's risk is the foundation of preventive cardiology. And in primary prevention, we use what's called the Ascbd risk calculator, which is available as an app for virtually every smartphone. And then you apply this to the prevention guidelines, which I'll talk about for primary and secondary prevention as it relates to lipid management. People are divided into 4 different buckets: low risk, less than 5% risk, borderline, intermediate, and high risk is 20% or greater. And remember that the calculator estimates the 10-year risk of a hard atherosclerotic cardiovascular disease event for people 40 to 79 and lifetime risk for people 20 to 59. And it's intended to just be a starting point to provide that patient-provider risk discussion and the best strategies to reduce risk. And a certain level of risk, such as 7.5% or greater, identifies statin eligibility, but it's not a mandatory prescription for a statin. So we have to remember that this is really the focus of the shared decision-making patient-provider interaction. And these are the different inputs required: age, sex, race, blood pressure, total and HDL cholesterol, history of diabetes and smoking, and whether the person is on antihypertensive treatment. The other ones are actually not required, but can help in the use of this instrument. So what I mentioned was that upon getting, and remember that only patients without established ASCVD should this calculator be used for. If you come up to be less than 5% risk, the focus is on lifestyle management. If you're 20% or greater, initiate a statin to reduce LDL by at least 50%. That will generally be a high intensity statin. Same goes for people who have an LDL of 190 or higher that is suggestive of familial hypercholesterolemia and diabetes, at least a moderate intensity statin. If you have multiple risk factors, a high intensity statin. Now, if you're in the borderline or intermediate risk, the guidelines first recommend consideration of finding out whether the patient has one or more of these risk enhancers. So they include things like family history of premature ASCVD, persistently elevated LDL, chronic kidney disease, metabolic syndrome, and for the first time in the guidelines, conditions specific to women, such as preeclampsia or premature menopause or gestational diabetes, also certain inflammatory conditions and certain ethnicities, such as South Asian ancestry or Native Americans are at particularly increased risk. Elevated certain lipid measures, including persistently elevated triglycerides, can be a risk enhancer, or elevations in HSCRP, LP(a), ApoB, or a low ancobrachial index that is indicative of asymptomatic peripheral arterial disease when less than 0.9. So if any of these are present, that can help motivate the treatment decision. But if that's still not certain, then we use coronary calcium if it has been measured. And this is something that's been dear to my heart because I've been involved in this area of research pretty much since I came to UCI over 30 years ago. And my colleague, Matt Budoff up the road, who I believe is on this call, he's done some of the most superb work in the world in this field. And what is noted is that, and this largely stems from work that Khurram Nasir did a few years ago, who's a cardiologist now in Texas, noting that if the calcium score is 0, it can really down stratify the person's risk to the point where they may not, if their 10-year risk is in this group, they may not actually necessarily benefit from statins. So you could actually delay or withhold a statin for a certain amount of time if the calcium score is 0. But if particularly the score is elevated, 100 or greater than 75th percentile, then statin therapy should be considered. And this very nice paper that Dr. Budoff published a few years ago involving 10-year follow-up of the MESA study, which I was fortunate to be a part of, showed that regardless of ethnicity, and we have a very multi-ethnic group here in California, that if one has a calcium score of 100 or higher, their 10-year risk is going to be at or above that point by which they would fit in a statin benefit group. So this really is, very much supports the guidelines of considering statin use, particularly if the calcium score is 100 or greater. And for each doubling of calcium, there's a 14% increment in ASCVD risk. Now, going back 25 years, I published this paper, and it asked a question about, well, if you get a scan, how might that motivate you? So we were able to show that different lifestyle and preventive therapies, new aspirin use, new cholesterol-lowering medicine, senior doctor, losing weight, decrease in dietary fat, also worrying, tended to be more likely in people who were scanned and had coronary calcification. In fact, I noticed that Dr. David Abrahamson is on the call today, and he was a collaborator with me on this study 25 years ago when he was at UC Irvine. Now, who else might benefit from knowing their calcium score? So what the guidelines say is that people reluctant to initiate statin therapy who want to understand their risk and potential for benefit more precisely. People concerned about the need to reinstitute statin therapy after discontinuation. So a high calcium score can really help motivate restarting preventive therapies. Also, older patients who may not have many risk factors, but they're wondering whether they might benefit, as well as middle-aged people in this borderline risk category that may have some risk factors, but are still on the fence about whether they should start taking statins. I covered this briefly already, just to reiterate that, that in most people with diabetes, at least a moderate intensity statin is recommended. If they have multiple risk factors or Ascbd, then a high intensity statin. And even younger people with diabetes who have multiple risk factors, a moderate intensity statin should be considered. Now, in secondary prevention, just to remind you of the guidelines, what is new is that we divide people into people who are at very high risk versus not at very high risk. And I'm going to talk about the distinction in a minute. But basically, the bottom line, without reading all these boxes to you, is that if one is on maximal statin therapy and the LDL still remains above 70, one can consider adding ezetimibe for these not at very high risk people. And ezetimibe, in addition, if needed, and the LDL is still 70 or higher, this is where a PCSK9 inhibitor is reasonable for these very high risk people. And I think it's critically important that those who fit in this group, that they be ensured access to PCSK9 inhibitors. And there have been some changes recently in some of the health plan coverages regarding this. So I think this needs to be looked at very closely. So what is very high risk? Why do we divide Ascbd patients into two different groups? And I wrote this editorial a couple years ago on this, based on this paper by Colantonio and colleagues that identified people at very high risk. And these individuals had event rates that overall were 3 times higher, 53.1 versus 17, compared to those not at very high risk. If you had 2 or more major events, your risk was actually 5 times higher. So very high risk is at least one of these major Ascbd events and multiple high-risk conditions, right? So a recent ACS, MI, ischemic stroke, or peripheral arterial disease, one of these and multiple high-risk conditions, or 2 of these, that's what constitutes very high risk. And so important to understand that distinction, because these are the people that will have a greater absolute risk benefit from the preventive therapies that we've been talking about. So as Deepak mentioned earlier, there's still, despite our statin trials that have been done, many people still suffer cardiovascular events. So this is the concept of residual risk. So you're optimally treated, but you are still suffering events. And remember that in these statin trials, the other risk factors were not controlled, because they really had to focus on testing the lipid hypotheses. So things like hypertension, diabetes, and smoking. And then this graphic nicely talks about all these other factors that might be responsible for residual risk. Very hot now in the cardiology field, of course, although we still got to get most of our cardiologists in the state and in the country on board, and they're not yet on board, is to think of these GLP-1s and SGLT2s as cardiovascular drugs. They're not just diabetes drugs, but they started out that way, yet we're finding that these are going to be the latest and greatest. The SGLT2s are going to be the next greatest generation of heart failure and chronic kidney disease therapies. There's been a lot of interest in how we might be able to attenuate inflammation, and a few trials have shown benefits. One with a monoclonal antibody, canakinumab, another one with colchicine. So, but yet we don't have guidelines to utilize any of these. And then we talked about how might we be able to further address the LDL issue. So we'll talk a little bit more about that. The Lp(a) being now on everybody's radar screen with the newer therapies coming on board over the next several years. And really, where does EPA fit within all of this? So what is important to understand is that, you know, we traditionally have classified triglyceride levels in groups, and normal is generally considered less than 150, borderline high 150 to 199, and so on. These are some data that our group published a few years ago showing that despite statin treatment, we are still finding that over 30% of US adults have suboptimal triglyceride level of 150 or higher. So this is, of course, an important impetus for these newer therapies, particularly Icosapent Ethyl. And as Dr. Bhatt nicely showed, there remains important residual risk from elevated triglycerides despite being at LDL targets. So this is an important group that has to be addressed. Navarre and colleagues showed from analysis from a combined study from the ERIC and Framingham offspring studies that the risk actually starts to increase even below 100. So this suggests the urgency that we not be complacent about people who are in this borderline high triglyceride range, and that we consider giving them the therapies that's going to reduce their residual risk. This diagram nicely shows that once someone is optimized on statin therapy, of course, we now have evidence from the Improve It trial that people benefit. People with a recent acute coronary syndrome within 10 days benefit from ezetimibe. Also, ACS within 1 to 12 months is shown by Odyssey outcomes, and stable Ascbd as shown by the Fourier study. Demonstrates the important use of PCSK9 inhibitors for benefit. And then finally, more recently, of course, both people with stable Ascbd or diabetes and multiple risk factors who had triglycerides of 135 or higher, as studied in the Reduce It trial, can benefit from Icosapent Ethyl. In diabetes, we have shown the value of multiple risk factor control. So people that get their LDL, their blood pressure, and their H1C at target have risk of cardiovascular events that are as much as 60% lower. So we have to get people to understand that diabetes is just not a blood sugar issue, it's a cardiovascular issue, and control of lipids and blood pressure. And we would also ask the question, would Icosapent Ethyl further reduce this diabetes residual risk? And Dr. Bhatt showed some nice data from Reduce It Diabetes, suggesting that you would get further risk reduction. So this is very important, a very important consideration for our patients with diabetes who have multiple risk factors. Paul Rinker had shown that despite high intensity statin therapy, here in the case of rosuvastatin, that many people do not get that expected 50% reduction, right? About half of people are not getting the expected reductions from statin therapy that are advertised. So we can never assume that somebody's going to get 50 or 60% reduction from rosuvastatin or high intensity atorvastatin. The fact of the matter is that there's great heterogeneity in response. And if you are an under responder, your event rates are going to be higher than if you respond well. So this is one of the problems about with statin therapy, besides the point that discontinuation rates can be high, and 15.4% discontinued within 6 months, and only half restarted statin therapy. There's a lot of data to show that half of people even discontinue within a year. And there are perceptions of problems like diabetes that are really not warranted. You know, we know that for every potential case of diabetes that could be the result of statin therapy because of a slight increase in glucose levels, there's 5 to 9 cardiovascular events prevented. So there's a huge disconnect into what the public believes is a problem and what they should be doing. Now let's briefly just talk about some of the newer therapies that have become available and where they fit within this. And I don't want to spend too much time on this because I want to make sure we finish in a few minutes here. But remember, bempedoic acid is an inhibitor of ATP citrate lyase, which is just a couple of steps above where a statin interacts. Remember, a statin inhibits HMG-CoA reductase. So like a statin, bempedoic acid reduces LDL cholesterol. It is not activated in the skeletal muscle, so it does seem to be much better tolerated and you don't get the myositis issue. As monotherapy, it reduces LDL about 15%. In combination with ezetimibe, it reduces LDL about 36%. So a very potentially useful agent in people that are statin intolerant, and bempedoic acid is FDA approved for both heterozygous FH as well as Ascbd patients who need additional LDL lowering because maybe they're not tolerating a statin or they're not adequately responding. Here's a study to show its use in people with statin intolerance, and you can see overall about a 24% reduction in LDL cholesterol. Inclisiran is soon to be approved by the FDA. It's been approved in Europe. This is a RNA interference therapy that that inhibits the production of PCSK9. It will be an injectable therapy like the PCSK9 monoclonal antibodies are. But what's interesting is that from injections at baseline, 3 months, and every 6 months thereafter, you're getting an average sustained 50% or so LDL cholesterol reduction. So one can maybe think of this as the closest thing we have to a vaccine against at least, LDL cholesterol. Now, there is an outcomes trial, and it's going to be important to show that demonstrates that this agent provides further CVD event reduction beyond statin therapy, just like the PCSK9 trials have. And finally, Lp(a) has become of great interest to many of us. Remember, this is an apple lipoprotein B particle that is connected to an apple A, and you find that it is largely genetically determined, and roughly about 20% of people have levels of 60 milligrams per deciliter or higher. So there may be as many as 300 million, and this prevalence assumes this many people in the world. And US guidelines do recommend we screen us in ASCVD patients, as well as, and universally, at least once in adulthood is recommended by the ESC guidelines. And there's quite a lot of data from meta-analysis, Mendelian randomization studies, and GWAS studies showing a strong relation to future event risk. We recently published these data in statin-treated people that were the subject of the AIM-HIGH cohort, demonstrating levels of 50 milligram per deciliter or higher to be associated with statistically significant increased risk of first events. Also, total cardiovascular events is important. And then there is a antisense oligonucleotide that will target the messenger RNA in development that can lower Lp(a) levels as much as 80%, and a large phase 3 trial that is in the process of being conducted that should be out by around 2024 or 2025. So Icosapent Ethyl, remember, was FDA approved for people with established CVD or diabetes and multiple risk factors with triglyceride levels of 150 or higher to reduce cardiovascular events. And that approval came out in December of 2019. A much greater advance beyond the prior indication that was limited to people with severe hypertriglyceridemia. As Dr. Bhatt mentioned, many of the guideline societies recommend it for our higher risk patients, particularly with triglycerides of 135 to 499. I think many of us, though, believe that people with lower triglycerides might even benefit. However, we have to stick with the evidence, which is from the Reduce It trial that enrolled people in that range. So these are people with clinical ASCVD or diabetes or multiple risk factors. Dr. Bhatt nicely showed this slide showing the preventable events per every 1,000 people treated with 4 grams a day, which is a segue into the study that I did showing that basically trying to estimate the preventable cardiovascular events in the US population that would be indicated for Icosapent Ethyl. And this was recently published in American Journal of Cardiology. And what we did is we estimated the eligible people based on a strict reduce it criteria to the extent that we had the all the measures available. And we also did this for the FDA eligibility indications. So we recalculated those numbers based on that. And from the initial and total published event rates in both the Icosapent Ethyl arms and the placebo groups from the REDUCE-IT trial, we then calculated the difference being the number of preventable events. So if you focus on the strict inclusion criteria, you get about 4 million estimated 3 million estimated US adults that are eligible for Icosapent Ethyl. If you, the FDA criteria, though, brought it up to about 4.6 million. Based on the strict criteria, we estimate preventing about 71 events for the primary outcomes annually. For the secondary outcomes, about 31,000. And you can also look at how many revascularizations and cardiovascular deaths and strokes are prevented too. And then we also did this in the primary and secondary prevention cohorts. And not expectedly, the vast majority of preventable events occur in that secondary prevention cohort. Finally, based on the FDA criteria, we actually estimate preventing about 60,000 primary and 42,000 secondary composite endpoints annually based on approximately 4.6 million US adults that would be identified as eligible for IPE based on the FDA label. So in conclusion, we estimated that there were about 3 million adults eligible with over 70,000 total events that could be prevented annually, 30,000 of which were initial events. And then this is increased by approximately 50% if you base the assumptions on the FDA eligibility criteria. So in summary, we've discussed that we have several different lipid pathways to address this residual. And the triglyceride pathway involving Icosapent Ethyl is an important one to consider. We've talked about the guidelines and where statin therapy is recommended based on certain levels of risk, the role of risk modifiers and coronary calcium, as well as the fact that many patients cannot tolerate statins and that there's great variability in responsiveness to statins, and therefore some of the newer therapies that have come about are important, and also there remains this residual risk. And certainly we're awaiting the outcome studies from some of these newer therapies, but really since the PCSK9 monoclonal antibody trials, it's really the REDUCE-IT trial has demonstrated, the great potential of Icosapent Ethyl to reduce this residual risk in higher risk people with moderately elevated triglycerides. 4 grams a day are recommended, and dietary supplements, remember, cannot be recommended. So I think with that, one study, last case study to end up with, a South Asian physician with no significant past medical history, some cardiac risk factors. He went into cardiac arrest, and he was identified to have a proximal LAD lesion and was treated for a STEMI. The LDL was then, after he was put on high intensity statin, the LDL was reduced to 88 and then 65 after the addition of ezetimibe. And his triglycerides still remain at 190. So what would you recommend? Well, you could give a PCSK9 inhibitor, but remember the guidelines do say once they recommended this be given only if the threshold LDL is still at 70 or higher. Fibrates, we still don't have the evidence that these work. And same thing with the combination EPA, DHA, omega-3 fatty acids. So really in this patient, it would seem that Icosapent Ethyl would be most appropriate and would fit within the guidelines. So with that, thank you for your attention. And I think Dr. Bommer will give a few additional remarks about cost effectiveness before we have it.
Thank you very much, Nathan. That was superb. You covered everything that I can think of, and we have great evidence so far that we have a process that we have gone through. I'm going to share screen here in a second and bring up
And I've just got to apologize.
my slides.
I've got to duck out in 10 minutes. I didn't realize on my calendar this was slated as going till 5 p.m. Eastern Standard Time.
Okay.
On the
we're-
Outlook invite. So in another
Okay.
minute, I'll have to sign off.
Thank you very much. I'll try to whip through this. We've talked about efficacy, which has been there. We've talked about literally the safety of these medicines, which have been demonstrated. And the last thing we're going to look at is access for individuals and cost effectiveness. So we're going to look at an evolution from phytoplankton to zooplankton to fish to pharmaceuticals. That process has literally taken a period of time. And I hope you can all see my screen. Is that correct?
Yeah.
Okay. All right. So omega-3s we've been talking about are very helpful for human health. You can see that EPA and DHA are primarily seen in marine individuals. And I'm going to flip through this. It started about 4 billion years ago. On the left, you can see some blue-green algae or cyanobacteria, and then other single-celled algae, which were able to produce billions of years ago in the oceans omega-3s. And both EPA and DHA have been recovered in these algae at relatively high numbers. In fact, when we say, where do we get fish oil? The fish get it from these marine algae. That's where it's in fact developed and produced, and the fish then process it from there. This shows in blue some of the organisms that are high in EPA, and they include some bacteria, they include some fungi, they include fish, a variety, a number are there. And for individuals who perhaps are vegetarians complete, then there is EPA generated, as you can see to the far right, in soybeans. So some plants have omega-3s as well. We've gone over some of the trials in omega-3 dosage, and what we see on the left is a more recent meta-analysis of 39 trials. And what it shows is the outcomes for cardiovascular disease seen on the left go down significantly in the column in the middle that is outlined in blue, anywhere from 5 to 35% reduction in cardiovascular events seen in the meta-analysis of different omega-3s at different doses for that. This shows the information graphically, which shows that in most of these, there is a significant reduction in myocardial infarction, coronary heart disease, fatal MI, and coronary heart disease mortality, which is seen with the separation from 0 on the plot, showing all of these lie in favor of the omega-3 trials. This is a quick trial or graph showing on the upper left the fact that there is a dose responsiveness that was seen here. The greater the dose, and you can see as you get out to 4 grams a day of these agents, there appears to be a greater reduction in cardiovascular events. Shown on the right in blue is about a 5% reduction in events per additional gram per day of the particular omega-3 preparation that is there. In this latest meta-analysis, they were not quite able to separate the difference in effect between EPA and DHA combination versus EPA alone that was demonstrated in the oh, gee, this has gone crazy, in the trial. So I'm going to flip back to this and hang on. So now we're going to look at some of the preparations and costs. This is, as you know, there are a number of over-the-counter, as was said, preparations of omega-3 fatty acids. This one contains both EPA and DHA for that. And the cost is seen on the right. These costs are $20 to $100 a month for these particular over-the-counter medicines for that. This is a more prepared preparation in Europe. You can see it has a little bit better ratio of EPA to DHA of about 5 to 2 in that ratio in a more purified form for that. As you know, the esters of the fatty acid may be more stable. So esters of both EPA and the combination EPA and DHA are available in prescription form. They contain either EPA exclusively or the combination of EPA and DHA. EPA is shown on the bottom. It's a molecule that is unsaturated, and DHA is shown below, which consists of 2 more carbons before it's esterified in the commercial preparation for it. So you can see the molecules are similar but different, and DHA does contain a longer chain, 2 carbons longer for the particular ester. We've talked today about Icosapent Ethyl. It has a variety of mechanisms whereby it may be cardioprotective, and we've discussed many of those today, in addition to lowering triglycerides. So there are other potential mechanisms, including increased or inhibition of oxidation and other processes in the cholesterol pathway, which may be beneficial. What is the cost of the commercially available omega-3 preparations? So for EPA and DHA, the prescription ones are shown on the left that are available. They range from $20 to $100 a month roughly. And for the EPA preparation, Icosapent Ethyl, that runs anywhere from $80 to $180 per month for that preparation. So the EPA exclusive preparation is a little bit costlier or more expensive than the combination of EPA and DHA for that. So for Icosapent Ethyl, it certainly is indicated to reduce high triglyceride levels. It is available through a variety of areas. If we look at the lowest cost price that is available today for the Vascepa preparation, you can see on the right that it's approximately $1,000 a year for this preparation. So this cost is reasonable at $1,000 a year, but is still costly for some individuals. The Blue Shield copay for a Medicare patient is about $90 to $100 a month. So that's roughly going to be about $1,000 for those individuals. The price of the Vascepa preparation fluctuates. Why? Because there is in fact a court case related to this. The two generic manufacturers have sued the manufacturer of Vascepa to strike out the patents. That is currently gone through a ruling in the court of Nevada and has now been appealed to probably the Supreme Court as of this month. That will vary on the cost of the product depending on that. Now, if we look at cost effectiveness as evaluated by the Institute for Clinical and Economic Review, this preparation shows that they had a price, wholesale price of about $2 one pill, 1 gram pill, and the net price with a discount was about $1 per price for that, leading to a net cost per year for individuals of about $1,600. Now, on the table on the bottom of this slide, you see that if we look at an annual price to achieve $50,000 per life year saved, which is a typical threshold that we use in the US for cost effectiveness, then that is cost effective if the price annually was $3,500 a year. Since the net price per year is $1,600, it's clear that on this analysis that this is a cost-effective preparation for Icosapent Ethyl at $50,000 per life year saved. This slide shows that the cost is not just of the intervention, but we do save money by preventing heart attacks and strokes. And so that the total cost for a patient on therapy is going to be about $40,000 for a patient on Icosapent Ethyl versus $31,000 when we include statins, other therapies, plus hospitalizations for that. That's a net difference of $9,000. The additional $9,000 for the Icosapent Ethyl therapy is going to give us about a half year of additional life in that individual. And here we see the improvement cost or incremental cost. Additional cost per life year saved is about $9,000. And you can see that that is very effective. And the total cost on the right per MACE avoided is about $53,000. Again, all of these cost analyses are less than the $50,000 per life year saved that we would advocate as a reasonable cost effectiveness in the United States. And the bottom table shows that literally we could double the cost of the Icosapent Ethyl and still have a cost-effective therapy at the $50,000 to $150,000 per cost life saved for that. And this is a later cost analysis done by Drs. Weintraub and Bhatt, who also showed that in modeling that in 85% of simulations that this was cost effective at these thresholds at the 99% level of simulations. So again, this Icosapent Ethyl is extremely cost effective at the $50,000, $100,000, and $150,000 range for both primary and secondary prevention, as we've seen. So if we summarize it here, the fatty acid ester of Icosapent Ethyl, we can see on the left that Nathan predicted about 3 million US adults are candidates for this at a cost of $1,000 a year. That would cost the society of US healthcare about $3 billion. That $3 billion a year is you can compare with our costs of about $400 billion a year for all therapies for cardiovascular disease, meaning a little less than 1% of our costs would be associated with adding this medicine to the 3 million candidates that Nathan predicts, which would save us then 70,000 events per year in the United States. And at that cost on the right, we see that that's about $42,000 per atherosclerotic cardiovascular event prevented for the use of this therapy. Again, less than $50,000 and a little bit less than the ICER cost, which was estimated at $53,000 per MACE avoided. So again, at the $50,000 level, this is a cost-effective therapy for that. And $50,000 is an accepted quality of life cost in the United States for it. Lastly, it's not just the cost to the patient, it's not the cost to society, but there is a cost to physicians. And that means when you order this particular prescription medicine, you will be required to fill out, in many cases, a treatment authorization for it. I've shown to the right the treatment authorization form for United Healthcare, and there are ones for the other insurance carriers as well. They're relatively straightforward, but this is additional work that your office or your staff will have to fill out when you write a prescription for some of these cardiovascular medicines. So in conclusion, to wrap it up, Icosapent Ethyl is effective. It has primary endpoint reductions of 25%, secondary endpoint reductions of 26%. Clearly, it is a very effective medicine, statistically significant. 2, Icosapent Ethyl is safe. As we've seen, that the treatment adverse event rates were very comparable to placebo across the board, with only a slight uptick in peripheral edema, constipation, and atrial fibrillation, and hospitalization for fib and flutter, which were close but significantly different. 3, Icosapent Ethyl is cost effective, assuming that the signals that we saw in the REDUCE-IT trial hold for patients treated with this intervention and our current net prices that I've shown. The results suggest that the cost for treatment with Icosapent Ethyl fall below commonly cited thresholds for cost effectiveness. And lastly, Icosapent Ethyl could further reduce residual cardiovascular disease and risk that are still rampant in the United States and globally as well. This is the end of my presentation, and now we can swing to questions and answers. So I will come off of this and we can go back to Q&A for the program.
Hello. It looks like we've lost Dr. Bhatt, but I'll start
Okay.
with an anonymous attendee put a question in the Q&A section, which is, does anyone know the post-marketing data for AFib in the Icosapent Ethyl population?
I do not personally know that data. In the
I
trial,
don't know.
there was a small increase in hospitalizations, but not severe hospitalizations for atrial fib and flutter. And there was a statistically small increase in atrial fibrillation. And we have seen that not only with Icosapent Ethyl, but with other fish oils as well, where there was a uptick in atrial fibrillation, but not severe atrial fib.
Yeah, and I think if I can add to that, Bill, I think that, one of the things when someone gets atrial fibrillation, right, they're most concerned about stroke. And remember, in Reduce It, there was more than a 25% reduction in total stroke with no significant increase in hemorrhagic stroke. So, I think most experts do not feel that the slight increase in risk of atrial fibrillation is clinically significant. And the head of the Data and Safety Monitoring Board actually was an electrophysiologist, and he wasn't concerned about that at all.
Well, it'll be interesting to see. I question whether or not maybe the COVID pandemic has affected the post-marketing data for, we'll see, because we all agree we don't have any data for post-marketing. Dr. Wong, you're left. I have a question for you. For the clinicians and medical payers that are not yet convinced by the wonderful evidence that and presentations today, what types of trials and numbers of trials or correlating studies or other data do you think they will need to be convinced of today's material?
Well, I think that's a very good question. You know, one has to realize that if you look at, and when I first heard Deepak Bhatt present the Reduce It trial at, I believe it was the ACC, the AHA, right, it's November 2018. You know, we were all so impressed by the number of zeros in the p-values. So, you know, this is not a borderline trial. We see many clinical trials where the, you know, significance is kind of borderline, and not all the endpoints or the component. Sometimes it's just a composite endpoint that is significant, and the individual component endpoints are not. But what was amazing with Reduce It was that every single pre-specified secondary endpoint was significant in the main trial, except for total mortality, that it was not powered to do so. But interestingly, in the higher risk USA Reduce It trial, total mortality was significant. So in US patients, we can actually say this agent reduces total mortality. So and then we also see the regression studies like the Evaporate study done by Dr. Budoff. So I don't know what other trials one would really need. You know, I suppose it would be nice to have a second confirmatory trial, but with the high significance levels of the endpoints seen in Reduce It, you know, I think we can all be quite certain that this is a real result, and this is a dramatic reduction in residual risk beyond not just compared to placebo, but beyond standard of care statin therapy. So that says a lot, because, you know, remember, many of the older statin trials were just in comparison to placebo, right? Yet we have everybody on the bandwagon, right, with statins. So here you have an even higher bar that had to be achieved for Reduce It beyond maximally tolerated statin therapy.
Sure. Well, thank you for that. And Dr. Bommer, do you see the follow-up question for you? Do you want me to read it, or?
No, I got it.
Okay.
Yeah, so there was a question related to the meta-analysis that I showed, and that meta-analysis was just came out this month, so it's a more recent one. Looked at data, and so it didn't show a difference now of that. And each meta-analysis has a different way of calculating the significant difference. I should point out that there was not a difference, but many of those EPA studies, some of them were lower dose. So clearly, and I think Deepak pointed it out, that you have to get a higher level of EPA to seemingly get this benefit. And his slides that showed the curves going down, you had to get far enough down in dose, that is a high enough dose, to get a benefit that you would suspect that smaller doses might not give you a benefit. And so some of those trials were 1 gram of EPA a day. And those trials, when lumped together in a meta-analysis, perhaps dragged down the single trial that you saw, which was the 4 grams a day, which is the Reduce It trial. So the problem is, if you have a very good trial like Reduce It with 4 grams a day, but you mix in with that other trials, you dilute some of the benefits. So if we look at EPA, including low dose, medium dose, and high dose, compared to omega-3, DHA, and EPA, low dose, medium dose, and high dose, there's not a separation. I think you have to isolate out the Reduce It trial, which was almost the single trial done at 4 grams a day of EPA. And you saw the blood levels showing double the EPA plasma levels in the Reduce It trial than in, let's say, the Strength trial. And the Strength trial had only 90, and the Icosapent Ethyl trial had double that level of plasma levels. So it's tough when we're dealing with supplements for the reason that there is dietary intake. And as you can see in some of the trials like Jealous, they were eating fish much more than we eat in the United States. And so they have relatively higher baseline levels of EPA than anyone else. And now you add your EPA or DHA component to it, and now you have to apparently do it at a high enough dose to make a difference. And I would say from the data we have so far from all of the trials, you're going to require at least 4 grams or more of EPA to get the benefit. You could look at the meta-analysis and say, hey, there's not clearly a statistical difference between all EPA trials and all mixed trials. So why don't I just do one thing or the other? Well, I would say that the answer to that would be, we don't know. That might help or it might not, but we do know one thing that does work, and that's 4 grams of Icosapent Ethyl a day. And we have data to do that. So until we determine the other aspects of what makes a difference, we have one proven therapy, and that's Icosapent Ethyl at 4 grams a day. And I would say for anyone with cardiovascular risk factors and disease, that's the one to be on now until we further explore this. And yes, there will be further trials in this to ferret out what are the exact contributions of each. Why does DHA, when added to EPA in the Strength trial, seem to counteract some of the benefits? Does it slightly raises LDL and other things? Could that be it for it? And we still have to deal with the idea that there were different placebos in the trials. And some people have felt that mineral oil might have been a negative placebo rather than a neutral placebo. So all of those things are out there. But if you had to reach for something on the shelf right now that's proven, and you were a high-risk patient and you needed that help, then that would be for Icosapent Ethyl at this time.
I have a question for Dr. Wong. Are you able to hear me?
Yes, absolutely.
So I was fascinated by the regression of coronary calcium related to the Icosapent Ethyl. And I'm wondering if you could talk about people who have very high calcium and maybe just borderline triglycerides.
Okay, so first of all, yeah, what you're talking about, I believe, is the EVAPORATE study, which actually used CT angiography, and their primary endpoint was low attenuation fatty plaque, which is what we expect is going to be modified by lipid therapy, not actually calcification. You know, we have used calcification as a marker of overall atherosclerotic burden, and it's in the guidelines because it is a risk predictor, okay? But we don't use coronary calcium per se as a marker of progress on therapy, okay? But what Dr. Budoff's studies have nicely done, and he's looked at other therapies too, is really, looking at total plaque volume or low attenuation plaque is a fatty plaque that is generally felt to be the plaque that will be affected by therapeutic intervention, and that is what the EVAPORATE study did show, and so I think the results are very provocative and provide further support to the anti-atherosclerotic value of this therapy. Hope that helps.
Yeah, I don't think we would recommend this to get rid of a positive coronary calcium scan. In fact, we know that statins, which significantly reduce events, they actually accelerate calcification in the plaque that is there. Coronary calcium is sort of a marker that you've got a lot of plaque. And if you've got a lot of other plaque, that's the plaque that's worrisome, that you really should be concerned with. The calcified plaque may be the most stable form of plaque that you have, less likely to rupture in many cases. Now, it depends on the pattern of calcification. If you have a large calcified plaque or a large area of calcium, that may be relatively stable. It's less likely that a piece of concrete will rupture. But at the same time, if you've got minute densities of calcium that are speculated throughout the plaque, those may be higher risk. So it's the smaller, tiny calcium inclusions that may incur the higher risk. Those are less likely to be seen on a coronary calcium scan.
Sure.
Yeah, we really think of it as a tip of the iceberg concept. So the more iceberg above the water, the more underlying plaque there is. And there is a rough but not perfect correlation between the amount of coronary calcium and overall atherosclerotic plaque. But the assumption generally holds that if you have a high calcium score, the more likely you are to have overall plaque. And there's a lot of data going back actually decades, studies that Dr. Budoff and others have done that show a high likelihood of obstructive angiographic disease, the higher the coronary calcium score is.
Yeah. So to Hattie's point, though, if it turns out to be true, Icosapent Ethyl may be the first therapeutic where, as we treat the soft plaque, we are not, it doesn't appear, at least in the initial data from EVAPORATE, that we are forming calcified plaque like we showed with the statins.
I think it's really hard to compare EVAPORATE to the statin studies. And again, the important thing you're looking at is the vulnerable low attenuation plaque, right? That's the plaque that's most likely to cause an event, as well as the overall atherosclerotic burden. So we're you know, less concerned about whether or not it has a significant impact on calcified plaque.
Thank you. I don't see any other questions in the queue. It is 2:24, so unless anyone else on the panel has any more questions.
Well, I have a question for Nathan while he's there. What do you think about mineral oil? I mean, is that something that we should avoid because of the increased risk in the placebo group in that was seen?
Well, so first of all, yeah, the mineral oil effect, you know, and whether that might have been responsible for some of the benefits seen in Reduce It. Most experts feel that it would be responsible for no more than 5% of the benefit. And in fact, if you look at the Jealous trial, remember, which did not have the mineral oil placebo, there was a 20% relative risk reduction. So the benefits still seem to be quite robust, even considering the potential effect of mineral oil. Now, what's interesting is that some people feel also, and this was raised by you know, Steve Nissen in you know, who published the last big trial, and he pointed out the increase in C-reactive protein that was that you get from mineral oil. So when you get an increase in CRP, you know, the concern is that that group is going to be at higher risk. Therefore, the, you know, effect of the Icosapent Ethyl arm could be exaggerated. But what's interesting is that, and Dr. Bhatt did not show these results, but there is a paper recently published where he showed that the effect of Icosapent Ethyl seen and Reduce It was the same regardless of whether or not there was an increase in C-reactive protein seen in the mineral oil placebo arm. So I think that kind of, you know, puts cold water on that hypothesis that any, you know, any inflammation induced effect from the mineral oil, you know, could have exaggerated the results of Reduce It. There just doesn't seem to be any evidence for that.
So I have an overarching question, and that is more of an invitation, Dr. Wong, and that is, we have been communicating with you a little bit about our umbrella concept of the get to zero equation. So we might see for people who have positive coronary calcium and they're at higher risk for an event, that you might see a 30% reduction with optimal statin therapy. So if we're trying to march toward zero preventable heart attacks and strokes, we'd like to actually put some numbers to if this therapy, statin or icosapent ethyl or bempedoic acid or SGLT2 inhibitors or PCSK9s, all these wonderful new agents in the armamentarium, how much could we drive that equation towards zero from where we are now? So we'd love to work with you on that.
Yeah, no, this is, I think, you know, everybody's goal in cardiovascular medicine and preventive cardiology is trying to reduce this residual risk as much as possible. But I think, you know, and I applaud you all for looking at these newer therapies, because I think they are definitely making a dramatic impact. But I think we have to also step back and we have to look at basics, okay? one thing that would be worthwhile to show and discuss, and I encourage you to look at this, is AHA's Life Simple 7, right? You've heard of Life Simple 7? Okay.
Yep.
So there are studies that that have been done, have been done that look at large cohorts and show that if you have all these 7 things at healthy levels, right? Cholesterol, blood pressure, glucose, physical activity, healthy eating, cigarette smoking, and obesity. If you don't have any of these factors, your risk is about 10%. That you have as much as a 90% lower risk than if you have multiple risk factors. So what I think is critically important is that, we work with our payers and healthcare providers to make sure that, patients and providers know where a patient stands on all these factors. And certainly the newer therapies go a long ways towards addressing the ones highest risk, right? So the ones at highest risk are those where, you're going to see a benefit from Icosapent Ethyl, from a PCSK9 inhibitor, from the SGLT2s. So, but let's, from a population level, we need to step back and we need to look at these basic things, and make sure that they're all at optimal levels and that our healthcare system is providing adequate support. I'm always astonished at how in a large HMO, there might be 500 physicians for every dietitian. So, there's something wrong there. We need to have more lifestyle interventionalists. We need to have the healthcare systems providing for multiple sessions with our lifestyle specialists like dietitians. And this was recommended in the 2013 guidelines to have up to 16 visits with lifestyle interventionalists in order to effect adequate behavioral change. So I think all the newer therapies are great, but we need to take a step back and make sure that, our healthcare system is supporting these crucial other members of the multidisciplinary care team that are going to make a difference at the population level.
Well, thank you so much. And I also want to invite everybody who's still on the line with us. Our next meeting will be on March 30th with the head of lifestyle medicine, cardiologist Collings from the Silicon Valley. And we'll also have Dr. Georgia at that time talking about the interaction between COVID-19 and diabetes, and how COVID-19 may be triggering both type 1 and type 2 diabetes, and to help us to understand that and what to do about it. Then on April 12th, we're going to have a wonderful program, Monday, April 12th, where we will be joined by the National Institutes of Health, Heart, Lung, and Blood Institute Cardiovascular Division Chief David Goff, along with the Cardiovascular Division Chief for the Centers for Disease Control, Janet Wright, and the former CDC predecessor of hers, Darwin Labarth, for a really spectacular program where we're also going to have many of our leaders, possibly including you, Dr. Wong, to talk about that get to zero equation. So with that, I just want to thank everyone, and I'll give it to the chairman for final closing remarks.
Well, thank you for our speakers today. Thank you for the staff for getting our Zoom conference rolling and smoothly. through the day and helping us get all the slides and everything together for that. We certainly appreciate that. Thank you for our participants for joining us today and, let's say, joining our crusade to try to further reduce cardiovascular risk, not especially in these individuals who have significant residual risk. And yes, Nathan is right. If we did everything perfectly from birth on, we could probably avoid atherosclerotic disease. But we do see some of it even in ancient mummies and other people. So we know it's been literally a disease process that has stayed with humans for a period of time. But we do now know significant ways of reducing it. And as Nathan pointed out, unfortunately, the simple sevens, if you look at the people who are following all of those, et cetera, it's a very small percent of the population, approximately like 5% of people who have no risk factors. That means that most of this we, in some sense, bring on ourselves. So we not only know the ways of reducing it and significantly, we have ways of doing it. We somehow have to find a way to sell this better to the population so that these dietary and lifestyle modifications are more easily accepted. And I don't have any magic answer to that. We have a primary and secondary prevention clinic that we have that has lifestyle, cooking classes, exercise classes, all of those things. And we find a group of individuals who are highly motivated who do this and get tremendous benefits. How do we draw the average person with cardiovascular disease into this? I think we still have to work on that. And that requires perhaps public service announcements. In the last year, we have, with the Surgeon General's office, issued a call to action to try to get this out. But I think we still have to do a better job of getting this information out to the public to show them the tremendous benefit that they can accrue from these relatively easy to tolerate lifestyle and diet modifications. And for those who have existing cardiovascular disease, they need to be on therapy. And we've explored today very effectively ways of trying to further reduce that residual risk in our mission to eventually get to zero. So on this day, this International Women's Day, we want to thank everyone for joining us. And we look forward to seeing you in the future. And have a great afternoon.
Thank you very much. Take care.
Thank you.
Thanks, everyone.
Bye.
Bye-bye.